Thank you, Dr. Bhavna, for having me in this nice session here. So in the next few minutes, I will be taking you through emergencies associated with corneal ectasia. Have no financial interest in the mention of any of the products during the course of my talk here. So just to summarize what all could be the particular concerns when you're dealing with corneal ectasias. One is it can arise, which could be because of collagen cross-linking related. Other could be because of contact lens wear. The ocular allergy, which could be associated with many ectasia, with ectasias, is another concern which can cause emergencies. Corneal hydrops is a particular emergency with any type of ectasias here. Then hydrops related problems and concerns and complications themselves can land up patients in emergency situations here. Keratoplasty in corneal ectasias. I think Dr. Fogler has already covered widely all those aspects of emergencies related to keratoplasty in ectasias here. And finally, but not the least here, it's trauma. So these are the various aspects one has to look at when you're looking at emergency situations in corneal ectasia patients here. So collagen cross-linking now, whatever be the protocol you do follow for your patients, depending upon the particular logistics of the ectatic characteristics here. The main complications, the main concerns which can arise when you're taking your patients through collagen cross-linking is some amount of corneal haze, presence of sterile infiltrates which can occur in the immediate postoperative period, infectious keratitis itself here. So infection is one. Always do look at these procedures as invasive procedures, and you would not want to have an infective keratitis on your hands when you're doing a collagen cross-linking here. There could be herpetic lesions which can get reactivated in patients when you're taking them for collagen cross-linking. Corneal edema in certain cases, and when you're not probably following the protocols on the depth involvement or the corneal thickness. Damaged or inadvertent endothelial cell loss could be another problem with these patients here. And again, continued progression, of course, that would not be an emergency here. So do remember, when the procedure is being done, it needs to be done as with all aspects or all protocols of a sterile procedure. We commonly do advocate take a conjunctival swab in your patients preoperatively so that you're taking care that the conjunctival flora is optimal and is not predisposed to any infections in these patients here. Preoperative antibiotic if you're taking these patients on here, and collagen cross-linking being done in a sterile procedure. Always do take care that the lids and the lid margins and the eyelashes are properly cleaned and going through your aseptic protocol for all your procedures here to prevent postoperative problems in these patients as well here. There are several types of enhanced protocols for dealing with thin corneas here. And again, be it whether you're using a contact lens assisted, a lenticule assisted, or the various custom protocols here. Again, these can be predisposed to infections during your procedure. So do take care that these are all not going to land up with problems in your patients. Important is to differentiate an immune infiltrate from a sterile infiltrate in your patients here. So immune infiltrates, the patients are not so symptomatic. They tend to be smaller in size here, usually peripheral, and you'll need to identify because you need to give steroids for this to go away. Vis-a-vis an infective infiltrate with a patient who's going to be more symptomatic, a larger area of involvement, and you will have to follow the protocols of management of an infective keratitis in dealing with these patients here. So that's going to be the difference when you are looking at managing postoperative infiltrates in collagen cross-linking for corneal ectasias here. Next, we'll move on to hydrops itself here. So hydrops is a unique concern which does occur on rupture of your Descemet's membrane here and can occur in keratoconus, can occur in pellucid marginal degenerations as well. So management dictums is, as all we know, the medical management is what we put the patients on is hypertonic saline and steroids, anti-glaucoma if required, and do cover them with antibiotics here because hydrops can get complicated with infections as well. Perforations have also reported to occur in cases of long-standing chronic hydrops patients here. Patients typically present with photophobia, watering, pain, and redness here. Corneal edema and haziness is all there in advanced cases, but you might not be able to see them when the patients are presenting early with just with a mild haze. Vision still might be good enough for these patients here. Those with chronic or severe hydrops patients, you would want to go in for an intracameral air or gas management in these patients here. Again, consider a very simple procedure. But do remember that if you are using gas, you will have to use a non-expansile proportion. It's 14% of C3F8 or 20% of SF6 here. And this when given in the early periods helps in rapid resolution of your corneal edema and clearing of the cornea and better visual rehabilitation of these patients. But the word of caution there is when you're using air or gas in these patients, you can land up with a pupillary block glaucoma or a malignant glaucoma in these patients. So that is something, and I have particularly burnt my fingers with one young patient here. So you always look at it with particular caution when you're looking at bubbling your eye drops patients in cases of chronic cases. Infection, perforation, malignant glaucomas are particular concerns. We do not see them very frequently, but if they do occur, they are going to be bad emergencies which you would not want to manage in your cases here. The mechanisms for corneal eye drops have been elaborated well enough here. The occurrence of microbial keratitis and its poor prognosis has also been elaborated in most cases here. And you could use the AIOC to look at the progress of your patients once you are bubbling them for management in cases of eye drops here. Again, the word of caution is look for pupillary block glaucoma. Be careful, and then whoever is assisting you, if your scrub nurse is preparing your gas concentrations, ensure that the concentrations are going to be non-expansile here, so you do not want to have a pupillary block or a malignant glaucoma in your hands here. Again, the evidence in literature also points out even when you've used non-expansile combinations of gas, there have been reported incidents of raise in intraocular pressures in about 6 to 18% of cases when you use them for RD surgery. The same can apply to your eye drops patients as well. So this is one particular patient who developed malignant glaucoma following intracameral gas injection in one of my patients here, and needed a lensectomy here for resolving the emergency situation. And then subsequently on went in, was able to rehabilitate with a secondary IOL and the graft for that particular patient. This is just a word of note for all of you if you want to look at how you need to mix your gases when you're making your 20% SF6 or a 14% C3F8, a rough guide, and which if you would follow, you would not land up with problems because of improper gas dilutions here. I think this is one fantastic latest paper here which does talk about a modified technique of using compression sutures for large and non-resolving eye drops here. So where you do use a modified technique of placing your compression sutures here and a simple air injection and a contact lens here, this does away with many of the other concerns which I just narrated to you about here. So this is an effective method and has been shown to work well in patients with large ruptures of Descemet's membrane. They are chronic here and does away with the need of other complications because of and logistics involved with gas injections as well. Next, we move on to concerns related to contact lens wear in ectasias here. So we do have a wide variety of contact lenses, starting from simple rigid gas permeable to modified RGP lenses to your rose-K lenses, and a wide armamentarium of semi-scleral and scleral contact lenses. But please do remember, for most of us who are fitting contact lenses in our ectasia patients, you do not want to land your patients on problems because poor fitting themselves can lead to a lot of corneal problems in terms of corneal staining, in terms of conjunctival hyperemia, in terms of increasing vascularization of the peripheral cornea, in terms of precipitating infection in these corneas here. So that's something you'll need to know on your logistics depending upon the type of lens you're fitting, particularly if you're using many scleral lenses, a very adequate teaching schedule for your patients here, and the patients need to be aware of the sterile way of removing and putting the lenses on and how frequently it has to be done depending upon the debris collection in the tear vault here. So these are important aspects which one has to reiterate to your patients who are on contact lens wear when you're managing ectasia cases. Another particular problem in corneal ectasias, particularly patients of keratoglobus, is trivial trauma or landing up with simultaneous or landing up with perforations without any predisposing trauma, evidence of trauma in such cases. This is one such case of keratoconus which is still following up with me right from when this patient was a child here, and especially if you have the association of brittle cornea syndrome here. This is a congenital anomaly, and this looks very similar to an associated Ehlers-Danlos here. But these patients do come to you with the recurrent corneal perforations even without without evidence of trauma or very trivial trauma with just touch of a finger here. And repairing these cases becomes particularly difficult because you will have cheese wiring of the cornea when you're passing sutures on here, and you will have to augment it with use of glue and with bandage contact lenses when you're managing these cases. So these are particular difficulties when you're managing corneal trauma in brittle cornea syndromes here. Again, the most important aspect is management of emergencies arising due to associated ocular allergy in corneal ectasias here. So one is, again, the corneal haze is very severe in cases of chronic BKC, chronic atopic keratoconjunctivitis associated with ectasias. The symptoms and the signs tend to be more severe in these cases here. More corneal haze here, more conjunctival problems here, limbal problems in these patients here. And of course, the occurrence of shield ulcer is one which you probably need to take on and manage aggressively in these patients. I think I won't run you through these because Dr. Fogler has already talked to you about, but then management of rejections in DALK is very important, because when these are picked up early, you would probably be able to reverse the rejections here and restore the visual rehabilitation which you have been able to achieve in your patients. Rapid suture loosening, especially in patients associated with ocular allergy, where the surface has a higher amount or a higher quotient of inflammatory mediators, is a particular concern, and the problems arising due to those need to be managed. I think I'll stop here and thank you for your patience.